Hello everyone to this new lecture. This one is the second lecture talking about this subject, that is the principle of oral diagnosis. In the previous lecture, we have talked about some condition of the patient that he suffers from, like the chief complaint, historical or examination of the history and dental history, including and medical history. We also talked about some physical examination, clinical examination, and we talked about extraoral and intraoral examination. Now we continue on talking about the intraoral examination. The intraoral examination contains two general forms. One is the examination of the dental structures intraorally, and the second is for the examination of the non-dental structures intraorally. Starting with the examination of the dental structures. In order to examine these structures, we need a number of tests like probing, percussion, vitality tests. These tests will show us the number of present teeth, missing teeth, and the causes of the missing teeth, whether it's oligodontia or hypodontia. Edentulous arch shape, whether it's a V or U shaped, whether it's a well-formed membrane or a flabby ridges of the edentulous ridge. The palatal vault, whether it's deep or a shallow palatal vault. In order also to see if there is a bony speckle, a bony tori, maxillomandibular tori, palpate also to evaluate for tenderness of the teeth, and to see if there is a mesiodense supernumerary teeth, distodense supernumerary teeth, paramolar or supplemental teeth. We have to also examine if there is dental caries on the occlusal, proximal, buccal, lingual, cervical, root surface. All these surfaces we have to examine whether the tooth is white, chalky, or dark discolor with cavitation. In order to see for proximal caries or to discover these types of hidden caries, we have to use Explorer, dental flows, and radiographs. More examination include the tooth attrition, the tooth mobility, whether it is grade 1, 2, or 3 mobility. We have to see the occlusion or molar relationship, English classification of malocclusion over jet, over bite, cross bite, open bite, and the crowding of the all part of or intraoral dental structure examination. Calculus and stains, fractured tooth, and enamel hypoplasia also must be taken in consideration. Now moving on to the examination of the intraoral non-dental structure. This picture shows us the most important parts of the oral structures internally, including the gingiva, the uvula, tonsillis, buccal mucosa, lips and cheek lining, floor of the mouth, tongue, anterior two-thirds, and retromolar trigone, soft palate and hard palate, teeth and lips. When it comes to the gingiva, there are the attached gingiva, then the marginal gingiva, and at last between the tooth and the gingiva is the pregingival groove. Next to it we can see the gingival margins and gingival sulcus. Gingival margin is at between the tooth and the gingiva, next to the pregingiva, and the gingival sulcus is internally underneath the tooth and above the gingiva. Next to it we can see the interdental gingiva, then the interdental papillae and the alveolar mucosa, then the mucogingival junction. We have to examine all of these structures, but mainly focusing on the marginal, interdental, and attached gingiva, commenting on the color, contour, size, and consistency, then examining whether the gingiva bleeds spontaneously on palpation or on probing. We have to use for this test, it's called bleeding on probing, using blunt-ended probe, and walk the probe along the gingival sulcus gently and recording sites that reveal bleeding from the gingival sulcus. We have to examine next the periodontal pockets. Periodontal probe is used to check the periodontal pocket. This one is placed in the gingival sulcus and walked gently along the circumference of the tooth, along the sulcus to detect for pockets. However, a pseudo pocket formed by merely a gingival enlargement should be distinguished from a true pocket, which occurs as a result of a loss of epithelial attachment, a pathological deepening of the gingiva. So there is pseudo pocket and true pocket. True pocket is obtained or formed by a loss of periodontal pocket epithelial attachment, and the pseudo pocket is caused by enlargement of gingiva. In this picture, we can see here we have the healthy gums and the periodontal pocket inflamed gums. In the next picture on the right, we can see that the definition of it is that the pathological deepening of the gingival sulcus. Again, pathological deepening of the gingival sulcus. Now we have to go to the buccal mucosa and see what is going on with the buccal mucosa. In order to do that, we have to retract the mouth using a mouth mirror. Well, when the surface of the mirror is facing the mucosa, and a glove index finger can be used to reflect the buccal mucosa also for inspection. Normally, buccal mucosa has a deep pink color. The clinician should inspect for change in color. If the color of the buccal mucosa is not deep pink color, then there is something wrong with the buccal mucosa. Presence of swelling, patches, and buccal on the buccal mucosa is also an indication of the problem. The lesion that we can see here can be palpated in order to assess its consistency and whether it's tender or not. In this picture, we can see the parotid duct here, parotid duct orifice, also called Stinson's duct, against the maxillary second molar. The next thing to examine intraoral non-dental structures is the floor of the mouth. The floor of the mouth is best visualized when examining the ventral of the tongue, ventral surface of the tongue. When asking the patient to touch the floor of the palate with the tip of his tongue like this, check for pooling of saliva in the floor of the mouth. And the best method to palpate the floor of the mouth is by manual palpation to check the Wharton's duct opening. By the way, Wharton's duct is another name for the sublingual duct, salivary duct or gland. This one, salivary gland, sublingual salivary gland, lies on either side of the lingual frenum. Here, as you can see in the picture, we can see easily the lingual frenum, and on either side, anterior part of the floor of the mouth, we can palpate the salivary gland. Again, it's on the anterior part of the floor of the mouth. When it comes to the submandibular gland, this one lies in the posterior part of the floor of the mouth. Now we evaluate the presence of tori, cyaloliths. This cyaloliths means stones that are formed by chemical interaction or chemical substance of the saliva. Next, we examine any nodular enlargement and enlargement of the salivary gland itself. The frenulum, as you can see in the picture, is on a solid arrow on the floor of the mouth. Sublingual gland is on the anterior part of the floor of the mouth under the buccal mucosa. It is here on the asterisk, and on the broken arrows we can see the submandibular duct orifice. Next, non-dental structure intraorally is called the vestibule. Now the vestibule is the labial and buccal vestibule. Here we can see the labial vestibule, and there is a buccal vestibule that can be inspected and palpated by asking the patient to keep his mouth slightly closed. And to keep the patient's mouth slightly closed, ask the patient to initially open his mouth wide as the clinician places his index finger on the vestibule, and the patient can be instructed to gently close his mouth and try to approximate his teeth. Now inspect the vestibules for swellings, ulcers, obliterations, the palate or the palpate the vestibule for tenderness, expansion, and cortical plates. Again, tenderness, expansion, and cortical plate. Here in this picture, we can see the maxillary labial vestibule showing the frenum and a bulge over the canine. That's the canine eminence. Next to it, we can see the canine fossa, which is a depression. And we can see also mucogingival junction that's marked with a broken line here, and also a sebaceous gland on the inner aspect of the upper lip. So we finished the vestibule. Now we have to talk about the tongue. The tongue is important part of the oral cavity non-dental structures. To examine the tongue, we have to see the dorsum of the tongue first, as the patient is instructed to protrude the tongue forward, keeping the mouth open. And to inspect the ventral part of the tongue, ask the patient to touch the roof of the palate with the tip of his tongue, like this. In order to check the lateral border of the tongue, a piece of sterile gauze is wrapped around the tip of the tongue, and the tongue is drawn to the desired side. The muscular consistency can be assessed by digital palpation to see the muscular consistency of the tongue. Here we can see in this picture, first of all, the papillae, follate papillae at a solid color, solid arrow, long color. Also, we can note the prominent submucosal veins on the intermittent broken arrow. That's called the submucosal vein. At last, we can see on the short, solid arrow something called frictional hyperkeratosis. On the other picture on the right, not the follate papilla this time, but it's the fungiform papillae on the dorsum of the tongue. This one is with a long, solid arrow. Then on the background, you can see the filiform and the circumvallate papillae on the short arrow. The short arrow representing the circumvallate. Anterior to it is the filiform. Then last is the fungiform papillae. Here in these pictures, we can see how we can discover and see the patient's dorsum of the tongue after asking him to protrude his tongue, keeping his mouth open. Also the ventral of the tongue touching the roof of the mouth with the tip of his tongue. And we have examined the lateral border here in the last picture. Just to keep in mind, and a quick note, there is difference between tongue and lung. Tongue and lung. And now to the lip. After we talked about the tongue, we have to know that the lip, both extraoral and intraoral surfaces, has to be examined. Also, the angle of the mouth next to the lip is also an important part that has to be examined. The extraoral part of the lip is pale pink in healthy individuals, and the intraoral surface of the lip, or the labial mucosa here, appears bright pink in contrast to the extraoral pale pink. Examination of the lip has to be conclusive of any pigmentation, presence of ulcers and swellings, or crusts and clefts. Next to the palate, beginning with the hard palate, that's generally examined by indirect visualization using a dental mirror. Its color is also pale pink, just like the exterior part of the lips, and it is hard on palpation and has a corrugated pattern in the anterior portion called the rugae area. Examine the hard palate for any change in color, ulcers, midline swelling along the palatal surface of the gingival margin of the clefts. Again, swelling along the palatal surface of the gingival margin and any clefts. Moving to the next is called the soft palate. This one is in healthy individuals more reddish in color. However, its color could vary according to its vascularization, and it is visualized by depressing the tongue using a mouth mirror as a tongue depressor. The soft palate is examined also for swellings, ulcers, but the soft palate is not palpated unless it is warranted, as it may cause gagging sensation in the patients. Therefore, it is very difficult to examine it with a palpation test. In this picture, we can see here the hard and soft palate junction with a dotted line here in this picture, dotted line for the junction of the hard and soft palate. Maxillary tuberosity of the thick arrows. Next, or opposite to the maxillary tuberosity on the maxilla, there is the mandibular retromolar pad area of the mandible that opposes the maxillary tuberosity. Palatal fova palatine. This one is thin, solid arrow posterior to the circumvallate papilla, to the fungiform, filiform, and foliate papilla. Of course, the palatine fova or fova palatine that lies posteriorly on the soft rugae area, as you can see anteriorly, represented with a broken arrow, and the incisive papilla represented with an asterisk, and there is also the midline raphe. Here in this picture, we can see the incisive canal canal, the greater palatine neurovascular bundle, the palatal glands, and the buccinator muscle, the raphe, uvula, and palatine tonsillis. In the right side picture, we can see the tonsillar fossa, uvula, and anterior pillar, and posterior pillar. Now, moving on to the tonsillis and oropharynx. This is the part of the posterior area behind the soft palate that is best visualized in the dental setting by gutting, or it can be gotten by pressing the tongue with the mouth mirror and instructing the patient to say ah, and here we can see the posterior pharyngeal wall and the tonsillar pillar, because ultimately we want to see the tonsillis, there is a tonsillis, and the oropharynx. We see, after doing this examination method, the posterior pharyngeal wall and the tonsillar pillar. Also, we can see the uvula and examine it. This whole part, including the tonsillar pillar, pharyngeal wall, and the uvula, are all considered to be part of the oropharynx. We have to take notice if there is any erythema, ulcer enlargement, tonsillis, exudate from the tonsillar crypts, etc. In this picture, we can see a tonsillar crypt, and it is well demarcated with a black, wide, short arrow on the right side of this picture. Within the crypts, there is some debris visible. Also, we can see a large tonsillis in the middle and a papilloma that is attached to the uvula with a long arrow that is represented. This one is papilloma. So again, in this picture, we can see a tonsillis, papilloma, uvula, crypts, and debris within crypts. To do more physical investigation and diagnosis, more clinical investigation and diagnosis, we have to rely on other methods other than inspection with visualization, and these methods include investigation with imaging, histo and cytopathological exam, and hematological, chemical, bacteriological lab examinations, one of which is serological, also can be included to see the serum of the blood. Starting with imaging, here we can see the radiograph is one method to examine the oral cavity, extra and intraorally. We can use in this method computerized tomography, CT scan, which provides a tomography, or can be called sectional clear image without or any superimpositions. This one is CT scan, computed tomography. Also, we can use contrast media with plain radiograph or CT scan. Example, salivary gland dactyliography. This one is with contrast media. Hollow lesion as cystic or blood vessels arteriography can be used. We can use this method to examine these types of hollow lesions, and that one is contrast media radiograph. Next, magnetic resonance imaging, MRI, mostly used with soft tissue lesions, and ultrasound useful for salivary gland. Also can be used with cysts and thyroid gland and soft tissue masses. In the radiography, we have conventional and computerized. Conventional like intraoral bite wing or computerized bite wing, periapical and occlusal view. Extraorally, we have cephalometric, OPG, PA, periapical view of the skull, and lateral view of and oblique lateral view, which is also very important, especially in surgery. Then we have the occipitomental Wharton's view, sinus view also can be called. Last one is the submental vertex view. In this picture, we can see the plane occlusal view at the first picture on the right. That's also showing us a stone Wharton's duct on the left and a cyalogram on the bottom right with a submandibular gland demonstrating an uncalcified cyalolithis in Wharton's duct. Uncalcified cyalolithiasis. wart instead. In the radiographic shape, there are sometimes unilocular or multilocular lesions, periapical abscesses on the left. We can see here on the left upper area on the screen, periapical abscess, cyst, granuloma, osteomyelitis here, and next we'll talk about biopsy that will show us any dentigerous cyst, leukemia, etc. The biopsy method includes the removal and microscopic histopathological examination of a part or the whole of a lesion. This one is simple, just removing it and examining it microscopically. Indication for biopsy is when we see an ulcer that persists for more than 2 to 3 weeks, or even after eliminating of the cause of the lesion, it will persist for 2 to 3 weeks. If we can see a persistent white or red lesion, a suspected neoplasm, an unidentified tissue mass, pathological mass, all of these situations, we have to make biopsy and handle the specimen that we take by using a 5 to 10% formalin that we store the biopsied tissue in this material. Many types of biopsy include incisional biopsy, taking a small part of the lesion, incisional biopsy. A sample, we can say, of the most suspected area. And this one should be relatively deep, large enough, and should include junction with normal surrounding tissue. That means we don't only take from the biopsy, from the site that we suspect there is lesion. We have to also take from sites that looks healthy to compare it to the lesion site. Excisional biopsy, a whole lesion biopsy is another name for it, used when lesion is small in diameter. So we do excisional biopsy, taking the whole biopsy, the whole lesion with one operation. Fine needle aspiration is accurate in differentiating between benign and malignant, involving lymph nodes. Especially this one can differentiate between metastatic carcinoma of lymph nodes, non-Hodgkin's, Hodgkin's lymphoma, all can be differentiated using fine needle biopsy. This procedure including 21 to 32 to 22 23 needle gauge inserted into the suspected lesion, and the minute piece of the tissue is sucked into the needle. The aspirated tissue is expressed into the glass swab, dried and stained, then examined with a microscope to determine if it's a benign or malignant. An exfoliative cytology is another biopsy. This one is examination of the cell scraped from the surface of a lesion or occasionally of a material aspirated on of the cyst. Exfoliative cytology. Brush biopsy with using a stiff breast brush to collect cells from the surface using vigorous abrasion, also collecting surface from the subsurface layer of the lesion. Here we have some examples. The first one is a benign hyperkeratosis on the upper side screen. Only a benign hyperkeratosis, even if it looks like a malignant tumor, but it is only a benign hyperkerotic cells. I'm sorry, I have made a mistake. The first one here is not a benign hyperkerotic cells. The one on the left, bottom left, is benign hyperkeratosis. This one is okay, benign left hyperkeratosis. But on the upper is squamous cell carcinoma, early squamous cell carcinoma. That was biopsied and concluded that this one is squamous cell carcinoma. The one on the bottom is only a candidial infection that cannot be seen very well in the picture, but it is a candidial. Same goes for the cytological examination here. Number one on the left, benign hyperkeratosis, then squamous cell carcinoma, early signs, and on the bottom we have a candidias. Next type of examination is the hematologic, chemical, bacteriological, and serological examination. In this type, complete blood count is tested to measure the number of red blood cells, white blood cells, hemoglobin in blood, and the platelet counts. The hemoglobin concentration can be for male from 14 to 18 milligrams per deciliter or 12 to 16 grams per deciliter for females. Erythematous normal value or erythrocytes, that's the red blood cells, from 4.5 to 6.5 million in males and 4.5 to 5 millions per millimeter cube for females. When there is a high number of red blood cells, this is an indication of low oxygen tension in blood, or congenital heart disease. When there is a heart disease, when you go to a high altitude, there is an increased number of red blood cells. Even congenital heart failure, pulmonary fibrosis, polyurythemia, or polycythemia. This one is increased numbers of hemoglobin and red blood cells. Dehydration also causes an increased red blood cells. Dehydration is coming from a severe diarrhea, for example, and kidney diseases also causes erythropoietin production, and erythropoietin high production causes excessive amount of red blood cells production. When it comes to low numbers of red blood cells in the body, there are many causes leading to this condition, one of which is blood loss due to hemorrhage, therefore there is a loss of red blood cells, anemia, bone marrow failure, for example, from radiation, toxic fibrosis. This also causes white blood cells count to be reduced and red blood cells count to be also reduced. Fibrosis, tumor toxins, radiation. Erythropoietin deficiency also after renal disease. So renal disease can cause high and low red blood cells counts. Hemolysis, when there is red blood cell destruction. Leukemia, multiple myeloma, malnutrition, such as nutrition with iron, nutrition of vitamin B12 and vitamin B6. PCV is the measuring for the packed cell volume. This one is occupied by erythrocytes. When we do centrifugation, we can see erythrocytes occupying 30 to 50% of the centrifuged tube. For male, it's 50% to 40. For female, it is 45 to 35%. When PCV increases, this is an indication of polycythemia, and when it is decreased, that means there could be an anemia. White blood cells count. For white blood cells, they are from 411,000. Neutrophils are the most types of white blood cells, then lymphocytes, then monocytes, then eosinophils, then basophils. And an increase of each specific type of white blood cells indicate some type of a disease. For example, an increase in neutrophils, that means there's a bacterial infection. Lymphocytes, there's a viral infection. Monocytes, there is TB, malaria, hepatitis, syphilis, or leukemia. Eosinophils indicating of an allergic reaction, and basophil, that means there could be a leukemia. Sometimes the number of white blood cells decrease. Why the white blood cells decrease? Well, there is many causes, some of which are bone marrow failure, for example, due to infection, tumor, fibrosis, radiation, for example, or presence of cytotoxic substance, autoimmune, collagen vascular disease such as lupus erythematosus. This one causes a decrease in the number of white blood cells. Diseases for the liver and spleen and radiation exposure, as I said. A high number of white blood cells, an indication for an infectious disease, also just like a low number of white blood cells, also an indication for an infectious disease. Inflammatory disease such as rheumatoid arthritis or allergy. Leukemia also increases the number of white blood cells. Severe emotional or physical stress and tissue damage such as burn. All these cause an increase in white blood cells count. Another type of examination is called the blood film examination. And this type of survey or examination, a stained blood is looked carefully for any abnormal cells. Abnormal white blood cells is an indication of leukemia. So we put this blood sample or stained blood sample on a film or a blood film to check for any abnormality with this blood or for this stained blood sample. Any abnormal white blood cells is an indication of leukemia or any other problem that we have discussed before. Red blood cells also show variation in size, shape, maturity, depth, staining in the blood film, such as normocytic, microcytic, macrocytic. The depth of color or stain is normochromic, hyper, and hypochromic. For an example, microcytic hypochromic cells, that means hypochromic small faint stain, and small size microcytic is an indication of low levels of hemoglobin, an examination of an iron deficiency anemia. When it is a macrocytic hyperchromic, large size, deeply stained, that means it's a pernicious anemia. Other types of examination is for serum vitamin B12. The normal value is 140 to 725 milligram per liter. Vitamin B12 deficiency is associated with a recurrent aphthous ulceration and recurrent candidiasis. That's a fungal infection. Folic acid deficiency, that is a serum folate level deficiency, also have a normal range from 1.9 to 9 milligram per liter, and its absence or reduction causes aphthous ulcer and recurrent candidiasis as such as vitamin B12 deficiency. The folic acid deficiency decreases in pregnancy, malabsorption, and diet deficiency. Therefore, a substitute supplement should be taken. HESR, erythrocytic sedimentation rate, is also can be measured, and it's a non-specific indication for pathological change such as arthritis and malignancy. Normal range for male erythrocytic sedimentation rate 15 milliliter to 0 in 1 hour, and for female is 0 to 20 milliliter per hour. More investigation about this blood film investigation or examination is about the clotting time. Clotting time normally is between 4 to 10 minutes in 37 degrees, and if prolonged, it is prolonged in factor 8 deficiency, that's called hemophilia, or factor 9 deficiency, that's a Christmas disease. PT prothrombin time from 9 to 12 seconds, and APPT, that's activated partial thromboplastin time, that's from 30 to 40 seconds. Bleeding time is from 1 to 6 minutes. It's less than clotting time. Prolonged bleeding time is an indication of abnormal structures of the capillary, that's von Willebrand disease, or abnormality in its function, and could be a cause of an decreased number of platelets. Platelets is 150,000 to 500,000 per millimeter square. A decrease in platelets or thrombocytopenia is an indication of leukemia or aplastic anemia. Now let's talk about the blood sugar concentration. This diagnosis of diabetes mellitus, which is clinically reflected of, so diabetes mellitus also have to be present, oral presentation of diabetes mellitus, and the most important things that the dentist focuses on when treating with diabetes is the burning mouth sensation and dryness of the mouth. In order to see if the patient is having diabetes or whether it's a controlled or uncontrolled diabetes, there is a fasting blood glucose or fasting blood sugar. This test is before eating breakfast, 12 hours of fasting. The diabetes test should range from 90 to 129 milligram per deciliter. And there is also a random blood sugar, not the fasting blood sugar. This one is random blood sugar test. For example, if a patient is going through an operation, surgical excision, we test his diabetes and see if it is between 140 and 200 milligram per deciliters. If it's more, we cannot do the operation. If it's less, we give the patient some sweeteners. Oral glucose tolerance is another examination or test, and its advantage is to detect the early stages of diabetes. The patient is instructed to take a 75 gram of glucose, then tests its glucose levels after half an hour, then 1 hour, then 1.5 hours, then 2 hours. If two of these tests is above 200 milligram per deciliter, that means the patient is diabetic patient. After 2 hours, the patient should have a normal range or a very low glucose levels below 126 milligram per deciliter. HbA1c glycosylated hemoglobin test provides a 120 days average blood glucose measurement or 3-month measurements. This one is the lifespan of red blood cells. It is 120 days. It considers an indication of degree control of diabetes. Normal value is 7%. 7% means the patient is having 170 milligram per deciliter. If it's more 8%, that means it's more than 200 milligram per deciliter, and that's not a good indication for a controlling of diabetes. The normal value for patients with no diabetes is 3.5 to 5.5%. But a patient with diabetes, a 6.5% is a good measure for HbA1c levels. This one is a page showing the most usual chemical normal value of blood, including electrocytes, enzymes, and other like bilirubin, albumin, uric acid, etc. And it's different in every lab, so this should be noted. Urinalysis or urinary analysis, it can measure renal, liver dysfunction, metabolic diseases like diabetes. It can provide valuable information and any presence of protein or blood with urination. That means there could be a renal or bladder disease, and finding of bilirubin in the urine could indicate a liver disease like hepatitis A, hepatitis B, hepatitis C. Bacteriological culture sensitive tests is a swab of microorganisms taken and identified and tested for antibiotic sensitivity. This one takes some time, but it is good to reduce or increase the sensitivity of the antibiotic and prevents antibiotic resistance, called bacteriological investigation, culture sensitivity. And types of diagnosis, reassessment. First of all, diagnosis, there's differential diagnosis. This one is the dentists have a good conclusion and explanation of the general finding of the oral lesion, and he lists the types of diseases that are most usually encountered with such symptoms and signs. Working, presumptive, provisional, tentative are also diagnostic types. Most likely diagnostic in the list of the differential diagnosis. So we presume which type in this list of differential diagnosis could be the presumptive, after eliminating all other diseases that are not justified and not frequently encountered in such lesion. Final diagnosis, after we have done initial, differential, presumptive diagnosis. Now we go to the final diagnosis. This one is the correct diagnosis. It results after the confirmatory test from the lab and after histopathological examination. After the final diagnosis, we determine a treatment plan and give antibiotics, antifungals, excisional, incisional biopsies according to the patient's need and type of the final diagnosis. Reassessment, the patient's system and re-examination after an interval of time is passed, and after treatment we have to do reassessment. Even if we have eliminated all types of diseases, a reassessment is important within specific intervals of time. Prognosis is a prediction. This one is the last subject. To predict where this disease and how long will it continue. Will it be eliminated, terminated, or it will have a poor prognosis? That means it will be metastatic and distributed in the body, causing death because it could not respond to the treatment plan that we have made after doing the final diagnosis. So the prognosis is the prediction of the future or condition of the disease, whether it's fair, poor, or good prognosis. And that was this lecture. Thank you for listening and watching this lecture, and goodbye.